How's everyone doing today? This will call to order our subcommittee hearing for Health and Human Services. Today we have two agencies or two reports that will be read out, and we'll take the first report and we'll have Ms. Ann Braun give us the report from Maryland Department of Health Prevention and Health Promotion Administration.
Great. Thank you, Mr. Chairman, members of the committee. Today, I'm presenting the budget analysis for the Prevention and Health Promotion Administration under the Maryland Department of Health. This is one of the offices under the Public Health Services Administration. The other offices will be heard at a later budget hearing for Public Health Administration. And so on the cover page, you'll see that the overall budget decreases by $65.8 million. This is mainly due to the expiration of federal grant funding that supported the state's COVID-19 public health response. There are some COVID-related funds still budgeted in the fiscal 25 allowance, and this is mainly reallocating funds that weren't spent from the federal grants in prior years. On page 2, the exhibit shows FIPA's budget when you take out those COVID funds, and so without the large decrease, the rest of the budget grows slightly by $9 million. That's driven by increased spending of federal and reimbursable funds, mostly for the WIC Nutrition Assistance Program and other maternal and child health programs. This is partially offset, however, by a reduction of about $30 million in special funds under the Maryland AIDS Drug Assistance Program, or MADAP. So I'm going to jump ahead to the performance analysis section on page 6. The first item discusses the prevalence of cigarette use among Maryland adults. Exhibit 2 presents self-reported data that MDH collects through the Behavioral Risk Factor Surveillance System. Over the past 10 years, there's been a significant decrease in the share of adults using cigarettes. This exceeded FIPA's goal from last year to reduce cigarette use by 31% between 2011 and 2020. However, that goal was not updated from last year's submission. And so I'll also point out that the exhibit includes data for high school and middle school students, but these surveys are conducted every other year. And so data on students' use of cigarettes and electronic smoking devices don't have updates for this year. On the next page, it discusses how FIPA has received increased funding through a mandate of $18.25 million for tobacco prevention and cessation programs. The fiscal 25 allowance includes slightly more, as it provides $19.4 million for this use. And considering this new state investment in tobacco prevention and then the lags in receiving outcome data, FIPA is asked to explain how it selects goals for the decrease in tobacco usage and to discuss whether more up-to-date measures would be available, especially around youth tobacco and electronic smoking device use. Moving on to the second performance analysis item on page 8. As part of the cannabis reform legislation, a new special fund was established under FIPA called the Cannabis Public Health Fund, and that supports uses listed on page 8. That includes data collection and research on the effects of cannabis legalization. It also funds education and public awareness campaigns for cannabis use. The allowance includes $5 million through the fund. About half of that supports grants to local health departments and community organizations. And then $1.15 million of that is provided to the new Maryland Cannabis Administration for a media campaign. FIPA has previously indicated that it would develop annual performance measures related to cannabis use, but this year's data submission did not include any measures on this topic. FIPA is asked to provide additional detail for the use of the Cannabis Public Health Fund in fiscal 25 and to update the committee on data collection efforts and potential MFR measures that could be reported in future years. DLS is recommending the adoption of committee narrative that would request MDH to include cannabis-related public health measures and goals in its annual data submission starting next year. So then moving on to the budget discussion, beginning with fiscal 24. On page 9, there begins an update on legislative priorities funded in fiscal 24. So first, there was $3.5 million added to implement the state plan to address Alzheimer's disease. $2.8 million has been spent so far on long-term care navigation programs implemented by the Department of Aging and other uses. And then the second item, $1.5 million, was added for grants to family planning service providers. All of that funding has been distributed to local health departments or subgrantees to offset increased costs or to expand programs for family planning services. And then $325,000 was distributed through a grant to the Center for Infant and Child Loss at the University of Maryland School of Medicine for grief and bereavement services. I'll note that these were all limited time initiatives as the fiscal 25 allowance does not continue the funding. And then the last thing I'll highlight in the fiscal 24 section is there is a negative deficiency that withdraws $5 million from the Pediatric Cancer Fund, and that is its entire fiscal 24 appropriation. This program was established through 2022 legislation, and it provides grants for research, prevention, and treatment. There is also a separate BRFA action that authorizes the transfer of $5 million from the fund's balance to the general fund. And so combined, those actions leave no funding for the Pediatric Cancer Fund. Moving to fiscal 25, Exhibit 3 on page 12 shows an overview of the agency's allowance. It is split over 5 bureaus, with the Maternal and Child Health Bureau accounting for the largest share. That's mostly due to the federally funded WIC Nutrition Assistance Program. I'll also highlight that the agency includes the Infectious Disease Prevention and Health Services Bureau, which manages disease surveillance and vaccine distribution. It also provides HIV and AIDS health services and substance use disorder prevention and harm reduction services. Pages 13 and 14 show the itemized lists of changes from fiscal 24 to 25. I'll highlight the $17 million reduction and then the $56 million reduction. Those are showing those COVID stimulus funds that are driving the overall reduction in this budget. The other changes I'll kind of discuss throughout, so I'll move on to the next page on page 15. This provides a discussion of the Center for Firearm Violence Prevention and Intervention. So this is one increase in FIPA's fiscal 25 allowance of $10 million in general funds for a new center. That funding is contingent on legislation establishing the center. There are administration bills that have been introduced to create the center with the responsibilities listed on page 15. And so some of those responsibilities are working with the Governor's Office of Crime Prevention and Policy on a whole of government approach to reducing firearm violence, considering recommendations from impacted communities, and submitting a preliminary state plan for a public health approach to reducing firearm violence by May 1st of 2025. MDH was unable to provide details on how the $10 million would be spent, but it did report that it would provide further detail to the General Assembly later in February. The funding is partly budgeted for $8 million in contracts and $1 million for grants. However, the duties outlined in the bill don't include grant distribution or programs to directly fund services. And so it's not clear that the center's responsibilities would require $10 million. The analysis also notes the October 1st effective date of the bill and the May 2025 due date for the state plan that is meant to guide the center's activities. And so DLS is recommending a reduction in this funding to provide $2 million to account for the later effective date and necessary startup time to establish the new center. Moving to page 16, there's a discussion of the Maryland Prenatal and Infant Care Grant Program. This program distributes grants to counties for care coordination services and for providers of prenatal care to improve access. Since fiscal 23, the program has received mandated funding levels that increase by $1 million each year. And so $2.1 million was provided in fiscal 24. Exhibit 5 shows how $1.4 million in grants have been distributed through a competitive process across the 6 grantees listed in fiscal 24 so far. There are still $736,000 in unallocated funds due to fewer program applications than expected. And so to spend these funds, MDH planned to offer supplemental grant awards to existing grantees and to repost the competitive grant opportunity. The fiscal 25 allowance for this program provides the required $1 million increase, and MDH reported that it would allocate that funding through the same competitive grant process without any changes to the program. And so considering the reported underspending in fiscal 24, DLS is recommending a reduction to that $1 million increase for this program and to instead level fund it at $2.1 million. Turning to the personnel discussion on page 17. The allowance includes funding for 100 new positions in FIPA, including 50 contractual conversions that were approved by BPW in October. I will note, though, those are not yet reflected in the fiscal 24 working appropriation. There were also 2 contractual conversions approved in January, and language in the budget allows for additional contractual conversions department-wide that are not shown in the allowance. The agency is asked to specify the timing of when the contractual conversions will be reflected and to describe the other 50 new or transferred positions and the need for them. Moving on to discuss the vacancy rate in January 2024, that was 9% or 42 positions. Because this is 10 more vacant positions than would be needed to meet budgeted turnover, FIPA is asked to discuss how it will spend the savings from lower personnel costs. So then I will jump ahead to page 19, where this begins the issues discussions. The first issue has to do with the Maryland AIDS Drug Assistance Program. Under that program, there's a special fund made up of rebates paid by pharmaceutical manufacturers to Maryland for HIV and AIDS drug purchases that cost more than a federally set rate. These rebates support services for individuals with HIV or AIDS, like assistance in paying for pharmaceuticals, insurance premiums, and copays, and then other items listed on page 19, like housing stability, syringe services, and pre-exposure prophylaxis or PrEP clinics. Turning to the exhibit on page 20, this has to do with the special funds closing fund balances and spending over the past few years. And so in recent years, the fund had closing balances of over $50 million each year through fiscal 22. However, most recently in fiscal 23, the closing fund balance dropped to about 15 million. In fiscal 24, FIPA is projecting that there won't be any closing fund balance. So this sharp reduction in funding is mainly due to reduced rebate revenues. FIPA attributed the revenue loss to more generic pharmaceuticals being available, an increase in 340B entities that can also claim rebates, and then changes in manufacturer rebate management processes that decrease rebates being paid out to states. So due to this trend of lower revenues, the fiscal 25 allowance decreases by $30 million in MADUP special funds, and that's to account for the anticipated lower revenues and then the unavailability of the fund balance. There is a major IT project that is that supports this program. It's the MADUP case management system that used rebate special funds in prior years, but the allowance includes $2.3 million in general funds in fiscal 25. And so in the budget books, there's a summary material on IT projects that listed a negative appropriation in fiscal 24. However, this project did receive an approved budget amendment for $555,000 in the special funds. And so FIPA is asked to clarify the fiscal 24 appropriation for this major IT project and why there was a negative appropriation shown. So then moving on to issue 2 that begins on page 21. This has to do with the WIC program, specifically enrollment. Exhibit 7 on page 22 shows that after 4 years of consistent decreases, the 23 enrollment grew by at least 2.2% in each eligibility group. So this contributes to the $22 million federal fund increase in WIC in fiscal 25. But FIPA indicated that the larger driver of increased WIC spending is actually increased food costs. And then finally, the third issue has to do with the maternal, infant, and early childhood home visiting program. This is a federally funded program to support evidence-based home visiting programs for pregnant women and parents in communities with higher risk of poor health outcomes. In fiscal 25, the program receives an increase of $2.4 million in federal funds, and that's due to the reauthorization of the program at the federal level. This funding will be used to expand the program to 9 additional jurisdictions for a total of 19. And the rest of this issue discusses a joint report from MDH and the Baltimore City Health Department on the timeliness of contract approval and fund distribution under this program. MDH discussed its multi-step grant award process that can take up to 6 months, and the Baltimore City Health Department reported on its award process that takes at least 4 months. On page 23, there's a list of some of the factors contributing to contract approval delays for subgrantees in Baltimore City. And on page 24, there's a list of recommendations from both departments on ways to improve the timeliness of contract approval. And so DLS found this report to be in compliance with the budget language and recommends the committees release the restricted funds. So if there are no objections made at this budget hearing, we'll process a letter to this effect. On page 25, this reflects the recommended actions that I've already discussed throughout this presentation. And so with that, I'll conclude. I'm happy to answer any questions.
Just one question. In reference to the 42 vacancies, was any of them for the extended amount of time?
That is a good question. I'd be happy to follow up with you on that and
Okay,
to look at the terms of how long those have been vacant.
Perfect. Seeing no further questions at this moment, if we can bring up the agency.
Good afternoon, Senator McCray, members of the subcommittee, Laura Herrera Scott, Secretary of Health. With me is Dr. Nalesh Kalyanaraman, who's the Deputy Secretary of Public Health, and Dr. Elizabeth Crom, who's the Director of the Prevention and Health Promotion Administration. And as always, thank you for your detailed analysis. And without any other comments, I'm going to turn it over to Dr. Kalyanaraman to provide the overview, and then we'll get into the responses to our questions.
Good afternoon, Chair McCray, members of the subcommittee. Thank you for having us here today. I'm going to briefly summarize some key highlights of our Prevention and Health Promotion Administration, and then summarize our written responses to the DLS analysis. The Prevention and Health Promotion Administration is a large unit within MDH that has a mix of general, federal, special, and reimbursable funds. And its work has a deep impact across the state to promote health and safety of all Marylanders. It's comprised of 5 bureaus, and I'm going to give you some brief highlights from each of those bureaus. The first one I want to touch on is maternal and child health. This bureau advances statewide efforts to improve health for women and children across the lifespan, from pregnancy and birth support to infancy, childhood, adolescence, and preconception care. Here are just a few of the highlights of their work. One is protecting reproductive rights, including launching a new partnership with Upstream USA to expand access to contraceptive care that the governor has highlighted, initiating the development of the Abortion Care Clinical Training Program, and standing up the new Protected Healthcare Commission. Another goal is advancing birth equity, especially Black maternal and infant health. And we're making strides on that by expanding the Centering Pregnancy model to offer a group-based prenatal care program that's been shown to improve maternal and infant health outcomes. And addressing complications due to hemorrhage, which is a leading cause of pregnancy-related deaths, through the Maryland Perinatal Quality Collaborative. The last item I want to highlight is how we're supporting behavioral health needs through the Strengthening Families in Recovery program to support pregnant Marylanders in recovery. The next bureau I want to highlight is our Infectious Disease Prevention and Health Services Bureau. This bureau's team leads Maryland's response to sexually transmitted infections, including HIV and viral hepatitis. Last week, the CDC released the 2022 Sexually Transmitted Infection Surveillance Report, which highlighted that 2.5 million cases of syphilis, gonorrhea, and chlamydia were reported in the United States, and in Maryland, that was 45,198 cases of syphilis, gonorrhea, and chlamydia. Of concern, syphilis cases continue to climb nationwide and here in the state, with a 10% increase since 2018 in Maryland, and with 46 congenital syphilis cases reported, representing a 55% increase since 2018. In response to this, Maryland Department of Health drafted House Bill 117, Senate Bill 305, which is Giving Infants a Future Without Transmission Act, to require universal syphilis screening at the time of labor and delivery for all pregnant women to identify additional cases of congenital syphilis that may have been missed during earlier screening opportunities. The next bureau I want to highlight is our Cancer and Chronic Disease Bureau. This bureau works to improve the health of Maryland residents to reduce the burden of cancer, diabetes, cardiovascular disease, tobacco use, oral health, to improve health outcomes across the lifespan. And now, mentioning all that, I actually want to pivot to one of the newest areas that we're working on within this bureau, which is cannabis. From 2018 to 2021, 9% of all adults reported current cannabis use. And from a different survey from 2021 to 2022, 39% of students have reported having tried cannabis at some point, with 22% reporting current use when surveyed. This data predates the implementation of adult use recreational cannabis on July 1st, 2023. With the passage of that bill, we've also stood up within the health department our cannabis public health branch to develop and implement our efforts to develop a data dashboard to monitor trends, support community-based programs to prevent youth use and misuse, to launch a statewide media and outreach campaign in partnership with the Maryland Cannabis Administration, and staff the Cannabis Public Health Advisory Council. There's obviously much work to do here, and we will be certainly sharing more information as time goes. The next bureau I want to highlight is our Infectious Disease Epidemiology and Outbreak Response Bureau. This bureau addresses infectious diseases, not including STIs, sexually transmitted infections, and HIV. And they do this work in partnership with state partners, including local health departments, academic health centers, other healthcare providers and laboratories, and federal partners, including the CDC, the FDA, and the USDA. This team is on the forefront of monitoring our respiratory illness season and leading infectious disease case and outbreak investigation and response, something that I think we've all become familiar with their tools from our experiences during COVID. So a couple of the items I wanted to highlight is that they are at the forefront of responding to the privatization of COVID vaccines during the fall of 2023, including implementing the new Bridge Access Program, the federal program for and underinsured adults, to make sure that they're able to access COVID vaccines. And we do that by partnering with pharmacies, adult providers, and FQHCs. They're also responding to the new tools for RSV infection, including the new vaccine for adults 60 and older, and for pregnant women, and also for the new monoclonal antibody product, Beyfortus, which functions almost as a vaccine. And the last bureau that I wanted to highlight, certainly not the least, is our Environmental Health Bureau. Our state and local environmental health workforce ensures safe food and water, inspects and investigates complaints related to retail and manufacturing food facilities, youth camps, swimming pools, and protects us from dangerous products. One of the key issues that we've had is a shortage in the workforce, but in order to meet the need, we need to be able to build up our environmental health workforce and our specialists. And that's where our development of an innovative apprenticeship program is critical to help build that pipeline, to be able to make sure that we're able to respond to emerging needs as the years go on. I'd now like to briefly review our written responses to the analysts' questions. The first item was relating to MFR goals related to tobacco usage. So the Maryland Department of Health collects adult tobacco use data through the annual Behavioral Risk Factor Surveillance System. This is an ongoing telephone-based survey to collect data on the behaviors and conditions that place Maryland adults at risk for chronic diseases, injuries, and preventable infectious diseases, and healthcare access and health disparities. For youth, we collect data through the CDC-developed Youth Risk Behavior Survey and Youth Tobacco Survey, and it's administered to students in Maryland public middle and high schools. And this focuses on behaviors that contribute to leading causes of death and disability. Both the BRFSS and the YRBS data are publicly available at the jurisdiction level and by age and race and ethnicity. The tobacco-related MFR measures were first established in 2000, and given the decline in cigarette use and sharp rise in electronic smoking devices amongst youth, in 2020, the MFRs were updated to include electronic smoking devices and any tobacco product use among youth. Each spring, the department completes an annual MFR measure review and updates MFR measures as feasible, and will continue to do so for tobacco-related measures. The next item was on planned uses of the Cannabis Public Health Fund in FY25. So over the past year, and I touched on this a little bit, but over the past year, MDH has developed the infrastructure to support a public health approach for adult use recreational cannabis use in Maryland. This infrastructure has involved hiring key positions, staffing the Cannabis Public Health Advisory Council, collaborating with key partners, including the Maryland Cannabis Administration and the Alcohol, Tobacco, and Cannabis Commission, and developing the framework for a data dashboard. Our Cannabis Public Health Fund distribution includes grants to local health departments and community-based organizations, media campaigns, legal and policy support, and personnel. The remaining funds will be used to further support local and school-based initiatives based on needs assessment. The next item is data collection activities related to adult use recreational cannabis. And so, as I mentioned, MDH has spent extensive time gathering existing data sources and working closely with our chief data officer to support the development of both an internal and external facing dashboard to address the public health impact of cannabis use. We've worked in close collaboration with the Cannabis Public Health Advisory Council to determine the appropriate data collection and reporting. Now, we do need at least a year of baseline data since the July 1st, 2023 inception of adult use legalization in order to set targets for adult and youth cannabis and public health measures. Once we have that data, it'll be reviewed and MFRs will be developed. The next item is the Center for Firearm Violence Prevention funding reduction. The department respectfully disagrees with this recommendation. Governor Moore is committed to addressing violence as a public health issue as one piece of the goal to create safer communities, and indeed highlighted this item in his State of the State address yesterday. The department will build upon existing injury and violence prevention work and existing partnerships with planning efforts already underway to support the center. And key to this is the prevention piece and really looking deeply at how do we identify the risk factors and the protective factors in communities so that we can truly prevent before there is firearm violence by thinking about how we can use data that exists and how we can collect additional data to really look at predictive analytics and ensuring that we are targeting communities for both homicide, suicide, and injuries to make sure that we are intervening before there's a problem and not only after there is one. This work would operate in parallel with creating a state plan, given the urgency of this work. Reducing funding will limit our ability to aggressively address firearm violence in Maryland and focus on true upstream prevention efforts. The next item I want to touch on is the Prenatal Infant Care Grants Program funding reduction. The department also respectfully disagrees with this recommendation. We must continue our efforts to decrease infant mortality, especially excess Black infant deaths. The $1 million is planned for allocation to Baltimore City and Prince George's County, the two jurisdictions with the highest excess gap of Black infant deaths. The next item is the discussion of the timing of contractual conversions in FY 2024 appropriation. So DBM has already effectuated the budget neutral FY 2024 realignments for 50 contractual conversions authorized at the October 25th BPW meeting. And in the coming weeks, DBM will be doing the same for the 2 additional contractual conversions that were authorized at the January 3rd BPW meeting. The next item is the FY 25 new positions. As we've seen with the COVID-19 public health emergency unwinding, we need to ensure that we have an adequately prepared state public health workforce. This allowance will help us build back state governmental public health in key priority areas, as well as supporting emerging public health priorities. And we're thankful that the allowance includes a total of 47 new state merit positions. Of those 47 positions, 37 are conversions of existing contractual positions supporting work in infectious disease control, maternal and child health, and chronic disease, and 10 are new positions to support the Center for Firearm Violence Prevention, cannabis public health work, advancing women's health, and oversight of youth camps. The next item was to clarify the number of vacancies in the vacancy rate. As of February 2nd, the Prevention and Health Promotion Administration has 39 vacancies in addition to the 50 contractual conversion positions authorized in October. The 50 contractual conversion positions have contractual employees who will be moving into those merit positions, as I mentioned. These 39 vacancies equals an 8.48 vacancy rate, which is just above our budgeted turnover, and we don't anticipate having significant salary savings from that. The next item is the MADAP Case Management System clarification. So the MADAP, the Maryland AIDS Drug Administration Program, case management system is critical for modernizing and protecting program participation information. It is supported by special and general funds, and this is a technical adjustment, and it does not reflect the change in the program's actual appropriation level. And then the last item is the release of funds in response to questions on home visiting in Baltimore City, and we thank DLS for the review and recommendation to release the funds. I will stop here, and I'm happy to answer any questions, as is our secretary and Dr. Crom.
Ready for questions? Yes, ma'am.
Yes.
All right, just checking. First, just thank you all for the work that you all do. I think it's the most appropriate statement to start off with. Just a couple questions. The one that I directed to Ms. Braun, for the 42 positions, do you know how many have been vacant for a long time extended period, or if there wasn't any long time extended vacancies?
So our response is similar to Ms. Braun's response. We'll have to get back to you.
Okay.
We do an aging report of all our positions. So we'll have to get back to you. So the information we get is accurate for you.
Okay. The when you gave the response for the plan for the center, like, I get the importance of it. Let me be very clear. I don't know that I know that I heard Ms. Braun say that a plan would be announced, I guess, mid-April. I wasn't sure if there was a plan or if you guys have gotten into it a little bit further to be able to extend like the $10 million appropriation.
So I'll start that. So we are working on a plan. The plan is not done. We are working with the White House as well to align with, certainly, the Biden administration, what they have put out. We have many pieces of the plan. The biggest thing that we're working on, though, is the analytics piece that Dr. Kalyana Raman mentioned. We're thinking about this a little bit differently than after the event has happened. So I'll give you a very concrete example. When our kids, for example, that are in school that have behavioral health issues, and the behavioral health issues don't get treated, then they end up getting suspended or kicked out of school altogether. And then that unfortunately starts a cascade in some communities where they end up in situations that promote or part of violence. And that's one example of how we could use data to wrap around behavioral health service, for example, or work with MSDE to stabilize those children and those families, to keep them in school, to keep them safe so they don't go down that pathway altogether. So it's going way upstream to identify risk factors that put people at risk for being violent in the future. So it's a little bit different way of thinking of how we want to use the center. So certainly predictive analytics is one of them, working with our researchers and some of the work that they're doing and taking models to scale. But we do have pieces of the plan. It's just not ready yet. And when we do, there'll be a budget that comes with it.
Okay. Will we see something prior to session, or do you?
I think it'll be done before the end of session. So you'll see it. We're shooting for April. So the second Wednesday of April, I guess we'll work with that date.
I'm going to go to the next question. I'm going to thank you for the work that you all are doing around maternal health. And can you just help understand, like, I heard you got two jurisdictions, Prince George's and Baltimore City, that the appropriations will go to. Was it any specific reason why they didn't apply for the competitive grants previous, because the money was returned?
I want to turn it over to Dr. Crom on this one.
Sure. So I don't actually have a specific reason for you why they didn't initially. But in follow-up conversations we had with both health departments, and actually the one in Prince George's County would be going to Greater Baden Medical Center. So they were able to actually say that they had the ability to take these funds and to continue the work that they were already doing and expand to more, basically to serve more individuals. And we thought that the need was so great, given just how great that difference is in sort of excess Black infant death in those two counties in particular, that we did not want to wait to put the funds out. We wanted them to be able to go and use those dollars right away.
Okay. One follow-up question to that specific subject. In your comments, you mentioned that $2 million was going to be possible decrease within Baltimore City around this specific subject. And you talked about private and public. What's the public fund decrease and what's the private fund decrease?
So we were notified by Baltimore City Health Department that they were expecting a sort of cliff of funding. We don't know what their private sources were. Our appropriation to them, the dollars that we fund to support them, is actually increasing for 25, or proposed to be increasing. So I'm not sure. I can't speak to what their other public funding sources were.
Any information that you have, I'm not going to also ask our health department, but getting a better understanding would be helpful.
Yeah, happy to go back and get that.
Yep. Last question, Madam Secretary, is a program, VIP Kids. It's work that in the past the health department has work with the coordinating center around these young folks that have specialized challenges. From that standpoint, there were grants that were administered from the Maryland Department of Health. It shifted over to RFP, I believe, with our local health departments. Some of our health departments responded. And some jurisdictions are moving in a posture where still addressing those young folks' needs. There were some jurisdictions that didn't accept or move in that direction. And my question is more towards the ones that didn't accept those resources, but the needs still exist. How are we addressing those needs at this moment?
So two parts to this.
Mhm.
One, Senator, is that there are three groups. So Baltimore County Health Department, Calvert County Health Department,
Mhm.
and then Talbot, Dorchester, and Caroline formed a consortium as kind of the third entity that are managing those VIP Kids funds.
Mhm.
Now, there's no geographical barrier or limitation. Children from any jurisdiction can get services from any of those entities. So I think that's the first part of it. So the second part, I'm going to turn that over to Dr. Crom as to why they haven't and what are the other resources for counties that may want to become one of those service LHDs.
Right. And so you were right in saying, so just because we have those particular counties being funded for the program, that does not prohibit a child from another county receiving services from that health department. So the 200 kids that are served within VIP Kids,
Mhm.
they can all still continue to be served. It might just be that they're being served by Baltimore County Health Department instead of the coordinating center. And I'll just say that this has also been a trend across all several states in terms of their Title V dollars in looking to standardize the care coordination that's done for our children, because local health departments are in homes and doing other things with regards to families. And so to put it all within a health department, to streamline and become more effective and efficient with those dollars, that's what the move has been. So that's why we made that decision to do that, to put the RFP out in that different way.
Yep. So the question that I would have is, knowing that geography, any jurisdiction can still be able to serve, understanding what is the drop off now that we shifted from the coordinating center to these respective jurisdictions, because I'm under the impression that you have folks in Western Maryland that used to be served by this respective grant program, but I'm not sure that in the jurisdictions that was listed that I heard a county in Western Maryland that filled out for this RFP and was successful, and just still wanting to make sure that those young folks have their needs service. So if you want to follow up, if you want to give comment, just saying, hey, when we were doing it with the coordinating center, this was how many young folks that was actually served, and this is what we were accomplishing. But now that we have this RFP, some jurisdictions actually were successful in saying, I want to partner with our health department, and how many young folks are being serviced will be very helpful, because you may be serving 199 and I just don't know, up to 200.
Right. Let's do that and get back to you on that.
Yes, ma'am.
We'll outline that.
Senator Zucker.
Thank you very much, Mr. Chairman. Madam Secretary, great to see you and your team. Appreciate everything that you all are doing around keeping our Maryland residents healthy. Just had I guess, two questions. One is, what's the status of the cancer moonshot initiative for statewide facilities? I know that we'd put in 10 million before. And then the second is, in particular, the Budget and Taxation Committee was very focused on treating pediatric cancer. And I'd like to kind of raise up Senator Michael Jackson, because I know he was just really a big proponent of it. And I think there had been $5 million allocated in the budget, and it's no longer there. So I just wanted to kind of get a sense from you on, what's going on. Because part of the reason why we put it in there was there's really no other area of the state that's treating, in particular, children. So just like an update on that, please.
So Senator Zucker, we've looked at this, and I think the key here is that MDH our focus is on improving the health and safety of our Marylanders, and really do that through disease prevention, access to care, quality management. We aren't really in the biomedical research space, and I think that's really well illustrated by the fact that while we have a lot of federal grants that come through the Maryland Department of Health, and that we then distribute to other entities and organizations, whether that's local governmental, local health departments, healthcare centers, academic health centers, biomedical research does not flow. Research funding from the federal government does not flow through the Maryland Department of Health, right? That goes directly to academic health centers and other entities. And so from our vantage point, there's a lot of money flowing already to both Hopkins and University of Maryland specifically, with approximately $1 billion in NIH funds. And when we look at our budget overall, we are trying to make sure that we are focused on the areas that are not being covered elsewhere. And so that includes those items like prevention. This is not really a question about the worth of those programs by any means. They're obviously critical. It's more about where does MDH focus its efforts on in light of the different funding streams and expectations.
Yeah, I guess I kind of understood that. I guess my question is that where's the funding going to pediatric cancer?
So when you say where's that funding?
Like, so in other words, you're talking about, I mean, you know, the overall budget is, you know, hundreds of millions of dollars. So, you know, we have agencies that are doing prevention within the Maryland Department of Health. We have, I mean, you have your fingers in a lot of stuff. So the whole reason why we allocated specific money toward this was to make sure, yeah, I understand Hopkins. I mean, that's why when they're asking for specific funding, we're allocating it for a specific purpose. So my question is where is funding going then to make up for the 5 million? Like, where's the money going for when it comes to, you know, helping children with cancer?
So we don't have the money in the budget. And I would actually ask the academic institutions that are here, since some of the monies that do come from NIH involve pediatric cancer, but it's not in our budget at this time.
All right, saying no, Senator Jennings.
Yeah, I apologize. I had to step out. You might have answered this. It's just a quick question. On page 8, the 1.15 million for media campaign and partnership implemented about the cannabis. Is this towards kids, and what are we trying to teach them? I know for cigarettes, it's all about cancer. What's the message to kids?
So I'm going to turn to Dr. Crum on this one.
Sure. So this is around education to prevent youth use. And we know from some of our early data sources around there's different levels of use depending on different populations. So in the LGBTQIA community, there's actually higher use among kids of cannabis. Something that happens with the use of cannabis in kids is there's a high risk of dual use. So using cannabis and also then using tobacco. And because of electronic smoking devices and the vaping, you can, vape cannabis. You can also vape tobacco products. So this would be around the sort of harms of dual use, the harms of cannabis use, and just safety in general, but that's targeting children.
Can I just also add on the data that we're tracking? So we started tracking from the very beginning. We are seeing an uptick in ED utilization related to cannabis toxicity. We're also seeing more calls to the poison center. So education would certainly help to address what we're seeing clinically in the ER and the poison center.
My question, like, what's the media campaign? Is it, like I said, cigarettes, it's about cancer. What is the campaign? Is it, I'm just trying to think of what I'm thinking of, the poster you'll see in the school of a cigarette with an X through it or something, cancer kills or something, I just don't know what the messaging is on cannabis.
So there's a couple of different messages, and we'd be happy to share with you the materials that we have so that you can see it, but it's really focused around for the youth, right? It's targeted around not using it and addressing that perception of that it's not as dangerous and not as harmful. For adults, it's really much more focused on safety, issues around drug driving, issues around storage of particularly the edibles or the consumables, right? Which can be left around, and that's where a lot of the poisoning
Is there if you use it, this will happen? I don't know what
yes, I see what you're saying, but it's more, it doesn't get into the question of if you do this, then this bad will. It's more focused on don't use it, right? And I think that you'll see the materials that we share with you.
Thanks.
There's also the basic education point too, to the point of safe storage. There's the dosing. So one edible isn't the same as smoking this or doing that. So having people understand too, knowing what you're consuming.
Senator Haldeman.
Thank you very much, Mr. Chairman, and I apologize that I missed the bulk of this because I was in a bill hearing in another committee. So I'm sorry if this is covered ground, and please let me know if it is and we'll take it offline. But I'm just wondering if you went into more details on the Center for Firearm Violence and Prevention and Intervention, sort of more meat on the bones there.
So we are working on the plan and we will have it by mid-April. That was the goal of the plan, the goal of the timing for the plan, but it includes many things, including how do we use data better, specifically around predictive analytics, not just creating another database, but how do we start identifying trends or profiles, for lack of a better description, so we can start developing resources to address them sooner. One of the example I gave was kids in school and behavioral health issues that aren't addressed. And once they get kicked out of school, sometimes the path to get in trouble that leads to violence. So how do we wrap services in partnership with MSDE around some of those kids as an example? And that there are models out there that talk about how to do that. It's been cited as a path, a school to prison pathway, and how do we stop that as an example? So it's really around data and analytics, certainly evidence-based research, and how do we partner with the researchers and some of what they're doing and translate that research into practice, and then take some of those initiatives to scale. And so that's the gist of the program. But really, we think of this as the pre-log, I would say, to what GoCap is doing. And so how do we even go even further upstream to the work that they're doing on crime prevention, such as safe streets, but even before we get to that.
So if I could just add one thing, and I'd be happy to talk to you about this, domestic violence it is definitely worthy of its being its own, since it is becoming more deadly. And I have something I'm working on. I'd love to talk to you about on that.
So we would as well, as you know, that especially for pregnant women, homicide is one of the primary
Leading
causes of death. So.
Yep. Thank you.
Seeing no further questions, Madam Secretary, at this moment, if we can bring up our academic institutions.
Thank you.
Yes, ma'am.
Good afternoon, Chairman McCray, members of the subcommittee. Thank you for this opportunity. My name is Kevin Cullen. And until last month, I served as the director of the University of Maryland Marlene and Stewart Greenebaum Comprehensive Cancer Center. I'm here today to thank you for your ongoing support of through the Cigarette Restitution Fund, but most importantly, to introduce our new executive director of the Greenebaum Cancer Center, Dr. Taufik Owanakoko. Dr. Owanakoko is an oncologist and internationally recognized expert in lung cancer and cancer drug development. He joins us from the University of Pittsburgh, and additional biographical information is provided in the slide deck that was submitted as part of our testimony.
Good afternoon, Chairman McCray and members of the subcommittee. It's a great honor to be speaking with you today and to thank you again for your continued support through the Cigarette Restitution Fund. I'm highly privileged to have the opportunity to direct a superb cancer center that came and owes its existence to the more than 20 years plus of funding and support from the state of Maryland through the CRF and the tireless work of my predecessor, Dr. Kevin Cullen. As you've heard over and over again, CRF funds have enabled the University of Maryland Greenebaum Cancer Center to build infrastructure that then allows us to recruit experts from across the world to come in and work at the cancer center. And the importance of this is this improves the prospect of cancer patients here in Maryland and around the world. CRF indeed has catalyzed federal cancer research funding, which has risen more than sixfold over the past 20 years, from an initial $19.4 million in federal research funding to the cancer center to about $122 million. I want to emphasize CRF fund and other support from the state helps us to build that environment, that infrastructure that then allows us to attract experts to come and work at our cancer centers and then bring the biomedical research funding into place. This provides not only better treatment and prospect for patients with cancer, but hundreds of jobs for Marylanders. In addition to biomedical research, the support of CRFs enables us to train the next generation of cancer scientists, starting from middle schoolers in our West Baltimore neighborhood, for instance. We've also provided cancer screenings for tens of thousands of uninsured and underinsured citizens in Baltimore, saving many lives through that program. In fact, we've screened almost 40,000 patients for cancer in the city of Baltimore alone. There are many, many ways to measure the impact of CRF on our cancer center and the state. But if we just count the total number of patients who have been treated at Greenerbaum Cancer Center and at our affiliated facilities of University of Maryland Medical System, those population of patients will fill the M&T Stadium 2.5 times over. And when we look at patients who have survived their cancer diagnosis because of treatment provided by our experts without having to travel out of the state, they will fill the Camden Stadium 2.5 times over. So on behalf of those 120,000 cancer survivors, who are your relatives, your friends, your neighbors, your constituents, citizens of Maryland, please accept our thanks and share our pride in the accomplishment of CRF. Thank you.
Chairman McCray, I'm Bill Nelson, the director of the Hopkins Kimmel Cancer Center, and I'm joining my friends from across town in expressing our deepest gratitude for the wisdom of the Maryland legislature in its oversight, by the way, and support of the Cigarette Restitution Fund. You know, the notion that our state could direct a share of its proceeds from the tobacco settlement, 1998 or whenever it was, into the Cigarette Restitution Fund is unique among all states in the country. It's really quite remarkable, we can tell you, because we interact with cancer centers all throughout the United States. And of course, that has been allocated to public health measures, which have been largely successful. Maryland cancer death rates continue to decline. It's a wonderful story. And to support research at the University of Maryland Greenerbaum Center and at Johns Hopkins. And we've taken that investment and steered it towards people and projects, 166 in total since we started. The people are tremendously exciting. I would encourage any of you who want to come and visit with them. These are the youngest, most talented people we brought into our institution, into the state. They're incredibly capable, diverse, modern, and it's wonderful to see their careers launching. They're very committed to hopefully ultimately eradicating cancer in their lifetime. The projects have been seeding new avenues of research so we can go out and bring in further support from the NIH and from other sources. We believe it's been about a 10-fold return on investment over the lifetime of our program, and to form seeding ideas that can lead to new companies that can be spun out. And that's been quite successful over the past few years as well. And so none of this would be possible, I believe, without the support of the Cigarette Restitution Fund program by you all. And so thank you very, very much, and happy to answer any questions.
Thank you. Any questions for academic institutions? I think it's definitely appropriate, and I said this in private, but just wanted to say it on behalf of the committee. Dr. Collins, just thank you for the work that you've always done and how you've always led, not just for city of Baltimore, but for the state of Maryland. And Dr. Awana Coco, just look forward to continued partnership and amazing work that you're going to do in the coming years. And Director Nelson, just thank you for pinch hitting, and look forward to continuing to be able to do the work that we do and move our great state of Maryland. I see the deputy secretaries back there, and just wanted to lean in and say just thank you. When we talk about important subjects such as maternal health, the use of cannabis, when we talked about the new center for firearms, like these are such critical issues in the state of Maryland. So I just thank you all for leading, and please pass that message along to the secretary and Ms. Brown. Always thankful for your leadership and everything that you do for our great state of Maryland. Colleagues, this will end the public hearing. I do have one more. I just see that National Minority Equality Forum. National Minority Equality Forum. Okay. Well, colleagues, this will hear it in the hearing for this. Say that again. You want to? Are you for this one? Yeah. Are you from the National?
No, I had some oral testimony for University of Maryland Capital Region Health. I wanted to let my cancer colleagues go first. I have
Oh, please.
brief comments if you don't
Please.
mind.
Yep.
Okay, Mr. Chair and fellow members of the committee, thank you for your service to the state and thank you certainly for allowing me to speak today. I am Michael Brozick and I'm privileged to serve as the Senior Vice President of Finance for the University of Maryland Capital Region Health. University of Maryland Capital Region Health, or UM Capital for short, is part of the University of Maryland Medical System. We operate the UM Capital Regional Medical Center in Largo, as well as other access points in Laurel, Bowie, New Carrollton, Suitland, and the National Harbor. Over the past few years, with the help of this funding from the state, we've secured services of an extensive list of net new specialists, more fully listed out in our written submitted testimony. And those individuals, those providers have helped us build new clinical programs in cancer, cardiac and vascular, orthopedics, neurosciences, and women's health. And this is all in addition to the breadth of medical specialists that are needed to staff our level 2 trauma center, which is the second busiest in the state, and the only trauma center in Prince George's County. The results of the state's investment in the build out of new clinical programs has been significant in both access to care and the number of residents choosing to receive their care at University of Maryland Capital Region Health. We've seen a significant growth in births, which are up over 200% since pre-COVID levels, focusing mostly on high-risk moms and babies. Our operating room time is up approximately 35% since pre-COVID levels. And we've also seen improvements, specifically reductions in the length of time patients need to stay in the hospital. To further illustrate the importance of this funding, UM Capital is building a comprehensive cancer center on our Largo campus, which will open in the spring of 2024, less than 2 months away. Our cancer program will provide education, screening, diagnostics, and testing for and treatment for breast, lung, prostate, and colorectal cancers. Through the development of these aforementioned programs, UM Capital has already helped reduce county outmigration by nearly 20%. And we've also received some significant recognition for these programs, including by the U.S. News and World Report, who's ranked us as high performing in the areas of heart attack, heart failure, heart surgery, diabetes, and stroke. And very recently by Health Grades, who has ranked us #1 in the state as the #1 stroke program in the state. So to wrap up, this critical and appreciated state funding is helping to build the care teams that will serve patients throughout Prince George's County and across the region. Simply put, we are seeing progress. I just want to end by thanking the subcommittee for your consideration and urge your approval for the 24 operating grant. Thank you.
Dr. Brozick, thank you. And we will continue to pass along the accolades. We're very appreciative of the work that you and the institution are doing for the state of Maryland.
Thank you.
Colleagues, this will move us on to our second part of the hearing, which is the Maryland Department of Health Administration. And at this moment, we'll bring up Ms. Naomi Kamara.
All right, thank you, Mr. Chair. My name is Naomi Camaro. I'm a budget analyst with the Department of Legislative Services, and I'll be presenting the budget for the Maryland Department of Health Administration, which includes the administrative and operational offices of the Department of Health and the 11 inpatient state facilities. The chart on the first page shows the funding for the Maryland Department of Health Administration and over the last 3 years. The fiscal 25 allowance includes $807.3 million, which is a $90.1 million increase from the working appropriation. On page 4 begins discussion of 2 different performance measures that the Department of Health collects and reports data on. The first is related to safety at the Department of Health facilities. MDH measures of safety, measures patient on staff assaults per 1,000 bed days and has a goal of having fewer than 1 assault per 1,000 bed days. The exhibit on page 5 shows the assault rate between fiscals 21 and 23. And you can see that in many cases, at many of the facilities, this goal has been exceeded, or rather this threshold has been exceeded, with particularly sharp increases at the John L. Gildner Rika Center between 22 and 23. The department is investing pretty significant resources into personnel in the fiscal 25 allowance. And many of these new positions are at these facilities and represent security positions. The second performance measure I'll discuss starts on page 6 and relates to the timeliness of court-ordered placements. So when individuals are deemed incompetent to stand trial or not criminally responsible, they may be court-ordered to seek treatment at the Potomac Center. And the Department of Health is mandated to admit these patients within 10 business days. Since fiscal 2020, the number of patients admitted within 10 business days has been decreasing, particularly since fiscal 2021, when the department was only admitting 27.1% of patients within 10 business days. And then in 22 and 23, that number decreased to 14.9%. And this is due to a couple of different reasons. First, there's been a sharp increase since fiscal 2020 of court orders. There's also been an increase in the severity of needs of these patients. And there's also a limited number of providers that the department can place these patients in after being discharged from the center, which would then open up more bed spots for incoming patients. In order to address this, the Department of Health reported during the interim in a JCR response that it has plans to expand the residential rehabilitation program and provide more investment for assisted living programs and permanent supportive housing. On page 8, I'm going to highlight a couple of parts of the fiscal 24 budget. The first is related to legislation that was passed in the 2023 session, which transferred oversight of infrastructure operations from the Board of Nursing to the Department of Health's Office of the Secretary. There was $8 million included in the fiscal 24 budget for this purpose, and there's $4.3 million included in the fiscal 25 allowance for this purpose. There's also reimbursable funds budgeted in the Board of Nursing for this purpose. And so the Department of Legislative Services is asking the Department of Health to discuss this transition, including the activities involved, and also explain the reimbursable funds allocated in the Board of Nursing budget. Further down on the page, I've noted 3 proposed deficiencies included in the 25 allowance. The first is a negative deficiency of $2.7 million, which is related to the oversight of the Board of Nursing operations that I just mentioned. The other 2 deficiencies total $2.7 million and are to supplement funding for budgeted turnover at the Thomas B. Finan and the Springfield Hospital Centers, which each have current vacancy rates of less than 5%. On page 9, this pie chart breaks out the spending in the Department of Health Administration budget. A majority of the spending, 59%, is allocated to personnel at the state hospital facilities. And a little less than 30% goes toward operations and administrative costs throughout the department, including for the hospital facilities. The chart on the next page, Exhibit 4, breaks out the spending for the administrative offices, which includes the Office of the Secretary, the units managing the operations and fiscal function of the Department of Health, major IT projects, and the Office of the Inspector General for Health. I'll just point out that 36% of this funding, $91 million, is allocated to opioid settlement funding, which I'll discuss in just a couple of minutes. On pages 11 and 12, there's a list of the major changes between the fiscal 25 allowance and the fiscal 24 appropriation. Again, the total budget increases by about $90 million, and that increase is driven mainly by increases in personnel costs, as well as additional investment in public health IT and data systems. On page 13, page 13 talks about personnel changes in the fiscal 25 allowance. So as I said earlier, the Department of Health is adding quite a few new positions. They've also created a number of positions through contractual conversion authorized by the Board of Public Works in fiscal 24. The number of new positions in 25 listed here does not include the new positions authorized at the January 3rd Board of Public Works hearing meeting. due to timing issue. But because of this, all of the new positions, DLS is asking MDH to provide a breakout of the new positions and their function and indicate which were created through contractual conversion. Moving to the next page, page 14, there's more in-depth discussion of personnel at the Department of Health. The Exhibit 6 on page 14 shows the vacancy rate over the past 4 years. And you can see that between fiscal 23 and fiscal 24, the rate has decreased by more than 3 percentage points. And it's also currently the lowest that it has been in recent years. On the next page, the vacancy rate difference between fiscal 23 and 24 is broken out by administrative offices and then the different types of inpatient facilities. So the long-term care facilities, there's 2 of them represented here. The behavioral health facilities include the 5 adult psychiatric facilities and the 2 regional institutes for children and adolescents. And then finally, there's 2 facilities for individuals with developmental disabilities. Again, in each of these groupings, the vacancy rate has decreased between fiscal 23 and 24. So in addition to decreasing vacancy rates, the department is adding many new positions. This includes 68 new staff at the John L. Gildner Reicha Center for a new unit. And DLS has asked MDH to comment on the function of this new unit. And then the last thing I'll say about staffing is that the fiscal 24 budget bill restricted funding contingent on the submission of a staffing and salary report, which has not yet been submitted. And so DLS is recommending budget bill language which would restrict funds in the fiscal 25 allowance pending submission of that study. Next, I'll turn to the overdose response in Maryland. On Exhibit 8, there's a chart showing the number of overdose deaths between 2015 and 2023, and then the number involving opioids. And so following a spike in overdose deaths in calendar 21 rather, overdose deaths have decreased slightly, but still remain above the pre-2018 levels. And also opioids are still making up a large share of the deaths. So MDH coordinates response through the Office of Overdose Response, which issues funding and collects and analyzes data. And this budget also includes the Opioid Restitution Fund, which receives funding from various settlements that the state is participating in and issues funding through grants. Legislation in 2022 established the Opioid Restitution Fund Advisory Council, which has released guidelines and recommendations for how to spend the funding. The fiscal 25 allowance includes $81 million from a Purdue Pharma settlement going into the Opioid Restitution Fund. And then on page 20, this exhibit shows the revenue and expenditures of the Opioid Restitution Fund in fiscal 2023. Page 21, Exhibit 10, again shows the grant funding coming out of the Opioid Restitution Fund by jurisdiction in fiscal 2023. And this covers a couple different grant programs. There's the the Office of Overdose Response Block Grant. There's also a Targeted Abatement Fund, which is issued to counties and municipalities according to the Janssen Settlement Agreement. There's also an Access to Recovery Emergency Gap Funds grant program, which covers emergency costs related to substance use disorder, including transportation, for example. And then there's the Examination and Treatment Act grants, which go to local detention facilities for treatment and other programs for people with substance use disorder. Because of the various efforts that the department has taken on to address overdoses, DLS is recommending adopting committee narrative, requesting that the department submit a report on the current efforts to respond to overdoses and how they're measuring the impact of these initiatives. And so with that, I'll just end by saying that the Department of Legislative Services, again, is recommending adopting budget bill language, restricting funding pending the submission of the staffing and salary study, and also recommending adopting committee narrative on overdose response efforts. And I'd be happy to take any questions if there are any.
Thank you. Seeing no questions, we'll bring up the agency.
Good afternoon. Thank you, Mr. Chairman, and thank you, DLS, for your thoughtful analysis as always. My name is Erin McMullen. I'm Chief of Staff at the Department of Health. And, thank you for the time today to speak about the MDH proposed administration budget and the alignment of funding to support the Moore Miller administration's priorities. Remarks today are largely going to focus on those 11 facilities that you heard about in the DLS analysis. And with that, I'll turn it over to the Deputy Secretary.
Good afternoon, Chairman Cray, Budget Subcommittee members. For the record, my name is Brian Morose. I am the Deputy Secretary for the MDH Healthcare System and Operations. And I wanted to take a minute to explain that long title because I don't think a lot of people understand the size and scope of those positions. So under operations, obviously by title, it supports the operations of the Maryland Department of Health. We do this through the Office of Contract Management and Procurement, which processes hundreds of millions of dollars in procurements for the health department. The Office of Facilities Management and Development, which oversees all properties and buildings that MDH maintains and occupies. The Office of Human Resources, and the health department being one of the largest state employees, is a significant role. And we also have our Secured Transport and Investigation Unit. It used to be called the MDH Police, but this title is very specific to what they do, which is transporting patients and investigation. The largest part of this and the title is the MDH Healthcare System. The overview of that healthcare system starts in 2021 with the formation of it. It oversees 4 service lines with 11 facilities. There are 5 adult psychiatric hospitals, and I use the difference between facilities and hospitals, so there's very clear. These are hospitals: Clifton T. Perkins Hospital Center, Spring Grove Hospital Center, Springfield Hospital Center, Thomas B. Finan Hospital Center, and the Eastern Shore Hospital Center. There are 2 regional institutes for children and adolescents, which we call RICAs, which we'll talk more about. There is RICA Baltimore and John L. Gildner RICA. There are 2 chronic acute care hospitals. This is Deer's Head Hospital Center and Western Maryland Hospital Center. There are 2 residential centers for individuals with intellectual and developmental disabilities. That is the Holly Center, the Potomac Center, and at the Potomac Center, that includes the Secure Evaluation and Therapeutic Treatment program, which is called SET. To give you a size and scope, the MDH healthcare system and all these 11 facilities serves approximately 1,900 patients annually and currently oversees over 4,000 staff with a budget of over $500 million. Our major initiatives this year include the relocation of MDH healthcare headquarters at State Center to 300 North Green Street. We are implementing and doing an analysis of the MDH healthcare facilities master plan. And we are continuing the standardization across all MDH healthcare facilities. We had mentioned that there were new positions coming to our facilities. We give a written statement of where those are and a breakdown of those, but I would like to summarize where some key areas of these staff are going. New merit positions include 400 new merit positions, which really aligns with Governor Moore's state of service. The first part, which I'll expand on, is JLG RICA, or the John L. Gildner RICA, Regional Institute for Children and Adolescents. And that is opening new units there to support children and adolescents who require competency attainment services and those who are experiencing hospital overstays. These are some of the most complex and acute youth needing behavioral health. The other expansion will be at Thomas B. Finan Center. The staff will be supporting 44 additional inpatient units, adult psychiatric beds to address the department's court-ordered hospital wait list. Also, many of these positions will be going to Spring Grove Hospital Center to support patient discharge initiatives to address the needs of that population. And that also includes those contractual conversions and new positions. A further breakdown of those positions are provided in our written response. I want to take a moment to explain the John L. Gildner new unit because I need to explain the services there. JLG RICA, which I'll call it, is for children, adolescents. It's a residential treatment center. Children go there for 6 to 9 months. They need support in sort of education, psychosocial, and medical services. And as I stated before, there are two of them, one in Baltimore. This is the one that's located in Rockville. Sources, how do people get into the regional institutes for children and adolescents? That's through foster care, social services, juvenile services, school systems, and other residential treatment centers. What we are doing on that campus is expanding the beds that are, or renovating beds within Cottage 2. It is 18 beds in total. 12 of those beds have already been renovated. 6 of those are for the facility for children, which I will explain in detail. And another 6 currently are for a high-intensity residential treatment center, which I will also explain. We are still working on another 6 beds to come online, and we anticipate that should be coming online in mid-2024. So I'll take a minute to explain what that facility for children is, because that's a little confusing. It is separate from the residential treatment center. The facility for children, or FFC, in statute is a multi-agency program with participation from the Department of Health, the Department of Juvenile Services, the Department of Human Services, and the Maryland State Department of Education. The FFC supports children and adolescents who have been ordered by the court to undergo competency attainment services in the Department of Health facility. So I need to explain that a little bit. An attainment services or competency services, often a youth is charged with a crime. They will go to court, and there's a question if they understand the charges that were brought against them and can they actually participate in the judicial system. If a judge feels that they cannot participate or there's a question, they need to be evaluated. Most of those attainment services can be done in the community, and they are done in the community. But there are youth that are have acute behavioral needs, which do not allow those services to be done in the community, and they need a place to go. That place cannot be a hospital, and it cannot be a detention center. So we've created the facility for children, which is on the grounds of JLG Rika. As I said, it's separate from the residential treatment center. We had 4 beds originally, but we started to have a wait list. We wanted to figure out how long that would last and anticipate. We do anticipate the need for those beds will increase, and so we needed to bring them from 4 to at least 6 beds as we move forward. The other beds that we are bringing online include those patients for a high-intensity residential treatment center. As we looked at those children who are in hospital overstays, we realized these are some of the most complex cases out there. They are children who need the most amount of support. They need the most amount of safety requirements, including staff. So those beds that we're bringing online are really to provide that high intensity level of support that those children will need. And I think I've described those, and I don't want to take up too much of your time. You did ask for a discussion of the staffing study. The department estimates that they'll be releasing that study by mid-February. That concludes my piece of this presentation. I'll stand by for any questions before I hand it off.
Thank you, Madam Chief of Staff, Mr. Deputy Secretary. Just a couple questions. Next week is mid-February. I just want to confirm that we'll be getting the staff report next week. The second one was that we have a number of folks that's going to give oral testimony, but there was one piece of written testimony that was supplied. I just want to give you the opportunity to be able to comment on it. It was sent by Dr. Howe, Chelsea Howe, and she talked about the position forensic psychologist or the lack thereof at the specific, I guess, facility that she's working at. I looked through your written testimony just to check to see if forensic psychologist was mentioned. If you can just elaborate in reference to this position, what you all are doing at the moment to try to help address this position. And inside her written testimony, she discusses just parity with other like institutions and what they pay.
So we are, I'm sorry. Thank you for that question. So we are doing, as part of the staffing and salary study, we're comparing the salaries to other states around us, other nonprofits in the community. We're looking at other institutions that we would compete with on those for staffing as we're all trying to scramble for clinical staff across the country and in Maryland. Just a little description of what that service does. It's an evaluation of patients. It's often done by a psychiatrist. The letter that you have is from a psychologist, so there are different levels of accreditation. and we have different pay scales. Even though they may be doing the same work, that level of accreditation does require certain salary adjustment in there. And so we are taking that into account. We're actively looking at that right now. So.
Just one more comment, because I think that anytime a constituent does write written testimony, I think that it's worthy of just leaning in on the issue a little bit more.
Sure.
It sounds like she's the only person that's filling the role in this, and that there's supposed to be multiple people in this role. If you could just dig into like, what is the vacancy like with this specific category at this specific institution that she's representing, so that we have a better idea. I heard you loud and clear in reference to the staffing study and what you're already trying to pursue from a pay equity or pay parity with other like institutions. But like, what does the vacancy look like with this specific position?
So I don't have that specific number for you, but I will address it in a general statement, which are those high level positions such as a psychologist and a psychiatrist are being competed across the country. We are running into shortages across the state in that and across the country. We are actively looking at that as part of our studies, part of our salary study, but there are definite vacancies in those areas.
If you can get back to the committee with, if there's just 2 vacancies, if there's 4 vacancies, if she's the only one, but also like how long has those vacancies been in existence would be helpful.
Thank you. We'll get that to you.
Yes, and specifically just for that classification. Just want to go back again and just thank you all. I really appreciated the tour that was given of Spring Grove, and just the work that you all are doing for the state of Maryland. And I walked away with a whole different position versus reading about it versus being able to see it. So I thank you for that opportunity.
Thank you. It means a lot to our staff to have people come out and recognize the work they do. We have some of the most excellent staff in the state, and they don't get enough credit. So thank you for coming out and doing that tour. It means a lot to us.
Yes, sir. Please don't go too far. It looks like there are a couple of folks from AFSCME that wanted to give public testimony. And at this time, I'd like to ask you to come up.
A quick question. Did you want us to respond to the other 2 prompts on nursing and overdose as well?
I know that we have your written response.
We have our written responses. Good with those?
Yep.
All right. Thank you.
All right.
Good afternoon. My name is Gordon Achu. I am a member of the AFSCME Local 266. I have worked in the Spring Grove Hospital for 16 years as an LPN CI. We appreciate that the budget added more positions. We still need more. We are very short staffing at the moment. For example, on a typical Sunday morning, it comes down to 3 staff. On the Red Bricks, which is about 37 patients. One of the staff will act as the charge nurse, the other one will be the medication nurse, and then 1 staff will be left with the 37 patients upstairs when they have to be upstairs after they eat or after breakfast or dinner. In that moment, it becomes very risky for the staff and the other patients because most of our job there is de-escalating patients from patients or patients against the staff. And this has been going on for quite a while. Currently, Spring Grove is also slated for closure, which with no plan to keep this level of services in the Baltimore area. This is impacting staffing also. We think this is a bad idea. We do great work at these facilities, restoring individuals to safely return to their communities. We have the only forensic juvenile unit in the state, and we need more resources for these children. The environment in which the children have been placed is like a jail converted to a children living quarters. Most of the time, the children are made to stay in their rooms. There are very few activities and very few staff. the children tend to act out because they want to go out to other places where they have amenities like hospitals. Some will swallow spoon, they swallow anything they can find. And majority of the day, we have codes coming from this unit because children cannot be contained. And because the facility was not really made for children, they act out the whole day, and both staff and children get injured around the clock. We also appreciate the staffing and salary study that is being recommended. We believe this should have been done in consultation with the union. Thank you for your continuous support for our work and patience.
Good afternoon. Thank you for your time. My name is Tradonna Pride, and I am the Vice President of ASME Local 266, as well as a security attendant at Spring Grove Hospital Center. I've worked at Spring Grove Hospital Center for 4 years. We appreciate that the budget includes some much needed contractual conversions. I want to speak to why this is so important. Currently, we have 88 security attendants at Spring Grove Hospital Center, and of them, 68 are contractual employees. Being a contractual security attendant is not ideal because of the high risk involved. As a security attendant, you never know if you will be coming home the same way you went to work. There are approximately 3 to 5 security codes called per shift. A code is called when there is a need for security assistance due to behavioral escalations. If an officer is injured, their contract is usually not renewed. Because of the nature of our job, we also face frequent false allegations, which prompts investigations and possible termination of their contract. Simply put, there's no job security. We need our officers to be merit employees. We will also ask if and when they are converted to merit employees that they receive credit for the contractual time. We have several contractual officers that have been with us since July of 2021. Thank you again for your time, and I hope we can count on you for your support.
Thank you, Ms. Pride, Mr. Achu. I'd like to call on Senator Hettleman.
So can you tell me what has been communicated to you about the winding down at Spring Grove?
Of the hospital?
In
Well,
terms of your jobs?
yes, just now, right now, we only know that it was sold to University of Maryland, and we don't know how long it's going to last. We don't know if any other facility is being built where this patient could be rehabilitated to. And presently, there is always a very long list, court list for patients who have been committed to come to the mental facility to join, but sometimes they don't have enough beds. And we just wonder what will happen if all of a sudden it's abruptly closed. Where would this population go to?
I understand that, but in terms of your positions, has anything been communicated to you about that?
No.
Okay. All right. Thank you very much.
Thank you, Senator Hettleman. And seeing no further questions, just Mr. Achu, Ms. Pride, just want to say thank you for your leadership and thank you for everything that you do for the state of Maryland. Like, we would not be moving if it's not for the folks that help us and get us to move. I know that you all are working with our young scholars. That's a vulnerable population, and just wanted to say that it's not easy, but I'm thankful for the work that you do. The whole committee is thankful for the work that you all do. Colleagues, seeing that this is our last briefing for the day, this ends the hearings for Health and Human Services. We'll see you tomorrow.